run in 3 parts. The first part, I will be sharing the what is the Ayurpreneur Academy and what this platform is for. So that is for 5 to 10 minutes, 7 minutes maximum. And then we'll go with the main topic of this today's session, that is what has been planned. And at the end of the session, third part will be the Q&A, okay, related to this topic, as well as anything which is related to the Ayurveda career. Okay, so let me start with my presentation, the presentation about what exactly the Ayurpreneur Academy means. Okay, for the confirmation. So basically, the Ayurpreneur Academy is the Ayurveda school of entrepreneurship. That is what why I founded this one is the problem what I found, what made me to found this particular Ayurpreneur Academy, and especially why to think about the entrepreneurship is in the last 20 years of my teaching as an Ayurveda teacher in the different various colleges and across the 2 states. And of course, as I visit a lot of the states also as a part of my profession. So I found that the Ayurveda education system is almost broken. I believe that you'll agree with me that 95% of the Ayurveda students who get their BMS degree, they are not capable, rather they are not confident enough to practice Ayurveda. And the multiple factors are there, but still, if the system is not giving them that confidence to monetize the Ayurveda, and that is what the problem, because that most 95% of our students, they are going towards the cross practice of the allopathy medicine and living a mediocre lifestyle with the general practice with the very limited reach geographically. So that made me to think over, because during the post-COVID, I felt that, especially in the COVID period, I could see that many of the non-medicos, they are making a lot of money using Ayurveda principles and being different coaches. Then why our Ayurveda students are not making it? And that is, I found that our education system itself is broken. So because of that, I felt that it needs a solution. So what is the solution? Solution is there is no clarity for our students. So there should be a clarity what exactly they are supposed to do with this Ayurveda. And they should have the competence, they should develop the competency, and by that they should have cash flow. So for that reason, I founded the particular Ayurpreneur Lifestyle Hub, wherein I am trying to share my knowledge as well as the other stalwarts of the Ayurveda who are already they have established their a good Ayurveda career. I will be inviting them, so that if the knowledge sharing is that, if that can help my students or all the Ayurveda faculty people, all the stakeholders to have that clarity, competence, and cash flow, that is what is required. And that is the solution what is required now. So the strategy, what is the strategy now? The strategy, there should be a system, there should be a community, and there should be mentorship. Because what I found was, if these three are there, this is what are the Ayurpreneur triangle, okay, where you will be successful and significant using Ayurveda. So you need to have a mentor who can guide you, okay, and mentor being the Apta, what we call. So Apta should be an advisor, he should be an appreciator, and at the same time, he should be strict enough to penalize when we are not drifting out of this track, and transform. He should be reason for transforming the students, and there should be accountability, and there should be community, because it is found that you will be average of the 5 with whom you are, okay. So if you have the community which is really going to support you, okay, and with that, if you are able to make your presence and you are able to make monetization of the Ayurveda, and you believe in Ayurveda, then you'll have that significant lifestyle and you will become successful. So the community should have that the 6 C's, that conviction, clarity, competency, confidence, consistency, and collaboration. And there should be a system for managing both the mentor and community, so that the system, because people may fail, but system will not fail. So that is why I felt that this should be a strategy where we need to have mentor, community, and system. And for that reason only, I founded this Ayurpreneur Lifestyle Hub. Now, what Ayurpreneur Lifestyle Hub is, with the purpose, okay, the purpose of the Ayurpreneur Lifestyle Hub is to elevate the self-confidence and self-esteem of the Ayurveda professionals, which is a very much need of the hour. And we, even though we deserve it, but we are not getting it. And the vision is to empower all the Ayurveda professionals with concept clear mindset and competent skill set to build Ayurveda entrepreneurship. And my mission is to help 1 million Ayurveda professionals to achieve and live entrepreneur lifestyle using their Ayurveda knowledge and skills to accomplish social and professional significance. What I am speaking about, the fame and that significance and financial abundance and time freedom using my Ayurveda business model. So what Ayurpreneur business model is? Ayurpreneur business model is I have made a business model which has got 7 what to call the streams of income you can generate, and that is like integrative medicine practice, pure Ayurveda practice, being in a coach, different because coaching business is now a 3 trillion business. Okay, especially that is the online coaching. Okay, and fourth one is the Ayurveda startups, and the fifth one is if you are technology passionate, and that you can use Ayurveda knowledge and technology, your passion and your knowledge can be combined, and you can make an entrepreneurial journey with the technology driven Ayurveda. And the sixth one is the research or the authorpreneurship, authorship in the Ayurveda. And seventh one is the Ayurveda farming. So Ayurpreneur Lifestyle Hub, the community membership, which what I felt that it should have the 6 C's in it. There should be community access, should be there, courses should be there for the continued learning. There should be validation certification for your milestones, and there should be coaching, like weekly coaching, what I'm doing. And there should be consultation for one-to-one consultation for any of your queries related to the career as well as the profession. And there should be collaboration of among all of us so that we can we can build our own ecosystem. So that includes the courses, which I name it as Ayurpreneur Business Bundle. And that is what the Ayurpreneur Lifestyle Hub actually is consisting of. Okay. So, but at the same time, once this Ayurpreneur Lifestyle Hub community it is guided by 8 code of honor. That is number one is the conviction, because if you don't have conviction in Ayurveda, you cannot survive in this community. And this community is meant for only those people who are believing they have got conviction in the Ayurveda principles and the results. Okay. And second one is the clarity. Okay. Second one is the clarity. So we should have this particular community is intended to give the clarity about the Ayurveda concepts, strategies, and communication and marketing and serving and the results using Ayurveda, either to start your clinic or start your career or start your entrepreneurship. Okay. So all of us who are people in the community, they should be acting as per these code of honors, where the conviction and they should move with a clarity what exactly for what they are here. Okay. And the competency to use Ayurveda as a vehicle to create their own brand and influence and multiple income sources. Okay. And confidence, because which is, I saw many of my students, they don't have that confidence, even though they are very intelligent students. Okay. So the confidence, especially to apply the Ayurveda knowledge efficiently to achieve their goal. Okay. And consistency, because the consistency can only yield the result. If we are consistent, we can create multiple streams of income using Ayurveda, both active as well as passive. And the collaboration is the most important thing, which is missing in our Ayurveda. Okay, we don't support each other, which is required. And this community is meant for supporting each other, because there should be a symbiotic relationship to grow together rather than competing with each other. So this community is to contribute for each other, not for competition. And we need to have that courage to make the global impact through Ayurveda to achieve our social and professional significance. And 8th code of honor is the freedom, which we are supposed to have, because you must be seeing that our Ayurveda graduates, they always they make a lot of money, but they lack this time freedom and financial freedom. Okay, so that is what this Ayurpreneur Academy stands for, the Ayurpreneur School of Entrepreneurship. Okay. So coming back to now, as all of you have joined, okay, before going to this particular presentation. Okay, so let me know how many of you are the practitioners, and from where you are, and what is your introduction, so that I can understand what exactly in what level I need to go to this session, so that it should be compact and crisp and clear for all of you, and it should be useful. So may I have your self introduction in the chat box, that from where you are and which place and what is whether you are a postgraduate, whether you are undergraduate, whether you are a practitioner, or whether you are a teacher. Okay, so that accordingly I can advance into the presentation. So kindly chat, type. Welcome to Safe in the Academy on the diagnosis and management of ano-rectal disease in general practice. See, the most of the cases, especially when it comes to general practice, let it be whether you are an allopathic general practitioner, okay, or you are purely doing Ayurveda practice, whatever the condition may be. But you must have observed that more than 60 to 70% of the patients, they come with the what to call the gut-related problems. And over the period, the same patient, they turn out to be having some problem or some complaints related to anal region. Isn't it? How many of you agree with me? If you agree with me, chat yes or type Y in the chat box. See, because I have seen in the last 18 years of my clinical practice as an Ayurveda surgeon, and especially when we become when we become an Ayurveda surgeon, and most of the time because of the limitations and those things, we switch over to the rectal practice. Okay, so and we are also known for that, because patients they expect that without surgery, if they can get the what we call the result, that is what makes us gives us a competitive advantage over our allopathic general practitioners as well as allopathic surgeons. Okay, so when this particular gut related problems, and especially when it comes to the anorectal region, because see, even though all of us we are walking ill, how many of you agree with me? All of us are walking ill because all of us we have got one or the other, what we call the or what the to the mild to moderate inflammatory gut with us. Because of that, many of us we suffer with acidity. Many of us on and often we suffer with constipation, bloating, flatulence, isn't it? And loss of appetite. So, and lack of what you call the enthusiasm. So that is called as a leaky gut. This condition is called as a leaky gut condition by the Western world. They are believing now that the leaky gut is the main reason for all the disease. That's what Ayurveda says, that the Amasya Samutta and Pakwasya Samutta Vyadis are there. And we neglected this part. We always think that the disease, as because of the influence of the allopathic science, we were treating them as a compartmental, and we are focusing only with the particular system or the organ. Whereas Ayurveda, right from the beginning, proposes that the disease starts at the gut. That's why there are Vyadhi Utpatti Sthana is always either Amasya or Pakwasya or both. Isn't it? How many of you agree? How many of you can recollect it? The Ayurveda always proposes that the Vyadhi Utpatti Sthana, if you see the Samprapti Ghatakas, it has been told that it is either Amashaya or Pakwashaya or both, depending upon the amount of etiological factors involved. And because of that, this particular disease, especially when it in the context of the Atisara or the Arsha or the Grahani, you can see all the three are interconnected. So the Grahani can lead to Atisara and Arsha can be the secondary to the Grahani or Atisara, and Atisara can be yielding the what you call the either Grahani or the Arsha. So they are interdependent. So this particular, even why I have taken up this particular topic today is, if we know the basic concept of the anorectal disease in the perspective of the Ayurveda, many of the disease we can prevent them from getting into a second advanced stage where the surgery becomes mandatory. So as an Ayurveda Vaidya, our prime priority should be to help the patient to have a very minimal, means very reduced or the very minimal chances of getting into invasive procedures or the surgical procedures. So if as a practitioner, as an Vaidya, if you're able to make out these particular, what you call the Pururupas, or if you are able to make out the Samprapti at the very earlier stage, you can definitely become, you can help these patients of anorectal disease with only medicinal management. Okay, medicinal. And the people always come to us only for medicinal management because they are scared of having any surgery at the anal region. And that is the advantage what we should encash. And by using our own classical, the remedies, wonderful remedy which has been given to us. Okay. So what are the common conditions? The common conditions are the external piles, hemorrhoids. See, why I'm using all these modern terminology is that it will become easy for you people to understand it because I want to help you to understand at the basic level. If you have forgotten the classical terminologies, I want to help you with these word terminologies so that you can be connected with and you can easily connect the patients what you have seen and the remedies what you can offer them, even though you are not the master of the Ayurveda. Okay, so the common conditions are the external piles, hemorrhoids, fissure-in-ano, perianal abscess, ischiorectal abscess, fistula, and anal warts. And at the same time, CANS is not much prevalently found, at least in my area where I have practiced, but still it exists as per the American statistics, it is more higher. Okay, and rectal prolapse, pruritus ani, sentinel piles, pyloric sinus, and rectal polyp. These are the common entities which you can encounter in your OPD. Okay, so this whatever, of course, this data may be of a US or the Western world, but still this data happens to be is same or even it is more than this in India. Okay, even at the age of 10, this disease can occur. That's why it is called as Mahagada. Any of these conditions, especially see, two conditions of the anal area or anorectal area or perineal area are considered under Ashtamahagada. That is, one is Arsha and another one is Bagandhara. So the bleeding hemorrhoids, anal fissures, abscess, fistulae, they are also seen at the very young age also. So it is not only acquired, it can be congenital. That's why Sushruta says that the surge Arsha is there. So even children can suffer with what we call the hemorrhoids. Of course, it can be a rectal polyp. First, we need to rule out the rectal polyp and then we can come to the hemorrhoids. So anal fissures are very much common even in the newborn also. Sorry, the infants. Even in the case of infants, anal fissure is more common. So that's why even before 10 years, in the first decade of their life, the individual can suffer with bleeding hemorrhoids, anal fissure, abscesses, and fistula. And over 10 million per year reported cases are there with the piles or the hemorrhoids incidence in USA. And the same holds good for us also. And the peak age is 45 to 65 years. And fistula is also having the good, means the ratio, 70 to 50%. And 35% patient will definitely develop in a fistula tract. Okay. And most of the time, they may be secondary to tuberculosis or in trauma. And the basic problem is the constipation. So whenever patient comes to your OPD, they come with a main problem of kabziyat or patient or the constipation. They always say this one. And this usually seen in case of the people who are chronically having the constipation. But what makes them to bring to the OPD is the what you call the complaints more often towards the pain and the bleeding or the what you call the prolapses. So the cancer, anal cancer happens to be the 3.2% of all the cancers for the death, whereas the prevalence of hemorrhoids, as I already told, 4.4% in the general population. Okay. And 14% of the people in urban India, they suffer with constipation, 10% over worldwide, and 20% in the age group of 45 to 65 years. So that all the multiple factors are there. Again, food habit is there, the sedentary lifestyle is there, and the non-adequate water intake is there. So multiple factors are there which are attributing or contributing for the constipation. And this constipation cannot be only harsh tools. Constipation can be the increased frequency with a very small quantity of defecation, means passage of the stools. It can be Muhurbadda, Muhurdrava Malapravrutti. Okay, it can be Koshtapaddhata. So don't consider constipation as only always Koshtapaddhata. Okay. So if you consider whole anorectal disease as a one bunch, hemorrhoids or the piles happen to be the majority of that. It means the major chunkies of the hemorrhoids or the piles, that is 51%. And fistula is accounted for 18% in US, but for India, fissure is more common compared to fistula. And anal fissure and piles, many times they coexist. And it is more common in men. Okay. So if I summarize these things, based on the complaint, what we can probably predict only on the history. Only on the history of the patient, once they come, they make their first complaint. You can think that this may be the probable cause. So if the first complaint is burning PR, most of the time, not most of the, almost of the time, it is a fissure or the proctitis. So burning, along with that, if they confirm that there is a streak of blood on the stool, definitely it's a fissure. And severe pain with perianal swelling, which may be associated with the fever, may not be associated with fever, can be a perianal abscess, perianal and ischiorectal abscesses. Because many times the patient fail to remember whether they have suffered with a fever. Okay, so painless bleeding, dropwise or stream, most of the time it will be hemorrhoids, especially internal hemorrhoids, which are first degree and second degree, because initial stage only the bleeding is more prominent. And painless bleeding, splash of blood is always see a rectum, especially the early morning, first bowel when they pass, if the splash of blood is there. The overnight collected blood in the rectum can be will be spilling in the vessel of the what you call the lavatory, and that is what is splash. And severe rectum should be suspected. Severe itching at the anal region in adult can be hypertrophied anal papillae, and prolapse of the mass can be internal piles or can be rectal prolapse, which is supposed to be distinguished on the distal examination or the proctoscopic examination or on inspection itself. External chronic and anal bulging is there, which is chronic bulging. I'm speaking about chronic bulging, painless. That can be external piles. And internal piles also sometimes they're coming out and they're going back and there's no pain. External chronic and bulging with the pain. External chronic and bulging, chronic anal bulging is with pain, then most of the time it is external thrombosed piles or the inflamed internal piles which are collapsed outside. And swelling of the undergarments, if the patient is complaining of this, always think about fistula or pylorus sinus or ruptured any abscess. Okay. So when it comes to differential diagnosis, how you can differentiate them? How you can differentiate? Okay. So usually the abscesses have got gradual onset of pain because there is a lot of space is there at the ischiorectal area and the perianal area. Their loose areolar tissue is there, so the space is there. Because of that, their stretch receptors of the skin are not much immediately come into action. That's the pain is not much immediately felt unless a huge collection takes place. So the tender and fluctuant mass, if it is physically present, then always think about the abscess. If any ulcerating and indurated lesion is there, which is painful with associated with pain and bleeding and changes in bowel movements and weight loss is there, cancer should be suspected. Varicose lesions are there, multiple lesions are there, condyloma can be suspected on physical examination. And once you see the visible tender fissure is there, okay, so that is usually tearing pain with the bowel movement, I have said. And swelling and itching complaint, along with that, if you are able to see any opening at the perianal region, that is fistula. And if the bloody diarrhea is there, abdominal pain is there, family history of such irritable means IBS are there, and possible fistulas are already existing there, and colitis on proctoscopy, anoscopy is, if you are able to make out, that can be inflammatory bowel syndrome. If the child is there, okay, and a plainless bleeding is there, polyps should be ruled out. Painful rectum, but no bleeding, and there is no any obvious, what you call the physical exam, means finding, then proctalgia, what you call the fugax should be, what you call the anticipated. Painful rectum and bleeding is there, tenderness on distal rectal examination, proctitis should be ruled out on proctoscopy examination. Rectal prolapse, which is, you can see a circular circumferential mass will come out. Okay. So that it can easily make out. And skin tags, history of hemorrhoids, no bleeding, and tags and covered with the normal skin. Normal skin. Okay. So most important thing, because when the patient when the patient they come to you, when they are very much fearful, when they are very much scared, then only they come to you. Because as long as patients are able to take care of their daily routine, they don't report any doctor, especially complaints with the rectal region, because it is not visible for them what exactly happened to them. Now, thanks to the advancements, even people now they come with the selfie of the anal region to show what exactly condition they are suffering with. But still, many of the people they don't report. Most of the people they don't report to the your OPD unless they have got that scare, what you call the fear when it comes to them when they see the bleeding. So when they see the bleeding during the defecation, then they'll come to you. Now you need to understand whether it is a painless bleeding or the painful bleeding. Okay, painless bleeding or painful. If the painless bleeding is there, that can be internal hemorrhoids, can be anal fistula, polyps, early stage of the cancer, okay, and other many other things are there which are not much common in, at least in my practice in the last 18 years. I have not seen any radiation telangiectasia, Kaposi sarcoma, solitary rectal ulcer syndrome, rectal varices. Of course, rectal varices can be related to that only, and of course we don't reach that much high. Okay, but usually they are not conditions, because anal hemorrhoids are more common in the Indian continental, and post-surgical anastomotic ulcer and polypectomy ulcer. Okay, these are very rare conditions which I have not seen. Even I have not seen in the last 20 years of my clinical practice. So painless, always, most of the time, what I have found is the hemorrhoids, then small anal fistulas and polyps in the children, and early cancers that should be taken into consideration. Painful are always, most of the time, thrombosis hemorrhoids will be there, and mixed hemorrhoids, anal fissure, anal trauma, advanced cancer, rectal abscesses, anal warts, rectal prolapse. Many times it may bleed. Proctitis ani and proctitis or colitis. So the basic, when in the last 18 years of my clinical practice, 18 plus years, almost 20 years, okay, 19 years now, 2005 I started my clinical practice. The major condition, three conditions I have seen in my clinical practice, especially ano-rectal region, and which you people also be coming across as a general practitioners or even dedicated clinical practitioner for ano-rectal conditions. Majority of these three. In rare, we get the rectal polyps, okay, and of course, perineal abscesses are common. I don't deny that. Hysterectal abscesses are common, okay, but these three happen to the bigger chunk, that is hemorrhoids, fissure-in-ano, and fistula-in-ano. Now, if you can differentiate only on these things, that will help you more easily to make out the decisions. So the hemorrhoids, the hemorrhoids, they will be having bleeding per rectum. They may not be having bleeding, especially hemorrhoids. When you call hemorrhoids, they should have bleeding. If you call them piles, they do not have the bleeding. So if they are not having bleeding, they should be referred as piles. If they have got bleeding, they should be referred as hemorrhoids. Okay. So in fissure-in-ano, severe pain at and after stools will be there. In fistula, purulent perianal orifices are there. And the hemorrhoids will also have prolapses of anal hemolysis. There may be constipation. There may be prolapse, strangulation, pain, discharge. Whereas fissure-in-ano, slight bleeding per rectum and streak of blood on the stools, and constipation and mass at the distal end of the ulcer, which may be sentinel pile. And fistula-in-ano is a purulent perianal orifice, occasional pain, indurated perianal area, and variation of presentation. Isn't it? So if you are aware of these things, how they physically appear, and these things you will agree with me. Okay, these are the common complaints they will be having. Okay, so by this you can easily make out what is hemorrhoid, what is fissure-in-ano, and what is fistula-in-ano. So hemorrhoids, they are the varicosity of the veins which are bleeding, which are at the below pectinate line, and they prolapse. They may prolapse, they may not prolapse. Fissure is a scar, a linear cut at the anal verge, which will be having severe burning pain and will be having streak of blood on the stool. Fistula-in-ano will be associated with either an existing abscess which has ruptured and led to opening, and that has become a fistula tract. So usually positions are there. The positions for the examination. Now you know the complaints. Now you have got the general idea that these can be this one. So need to confirm it with physical examination. So usually most of the surgeons, they prefer lithotomy position. I prefer the left lateral or the Sims position because it gives what you call the comfort for the patients. It won't embarrass them, especially when the female patients are there. And of course, when it is a fistula case, when I suspect it is a fistula, I go for lithotomy position. But when it is not fistula, even the left lateral position can do a lot of, it can give a lot of access for the that perineum area, and we can confirm our diagnosis. Okay. So on inspection, if these three conditions, these are the multiple conditions, so what you can see, especially when related to external piles and external pile hemorrhoids. So usually piles can be divided into three. One is purely internal. Second is purely external. Third one is intermediate, that internal external. Means internal, it has got both the components. Now, if you are able to see my cursor, these are the purely external piles. You can see they are covered with the skin covering. There is only skin component, the component is covered by skin. So these are the purely external piles. This one, what you're seeing, this is internal external, because you can see there is there is a line which is separating mucous covering and the skin covering, and this suggests that this is the internal external piles. Okay. If this is why? Because it is internal external, because both the components are existing. That is skin covered and the mucous covered. Whereas this happens to be thrombosed external piles, which has got a black stage A. Figure number, the picture, what is designated as A, it is the external thrombosed pile mass. Okay. And here you can see the congestion in the internal piles. Okay. And here again, it is anal bulging is there in the C. In the picture C, anal bulging is there, which is suggestive of internal piles. And D is, here you can see again, the 7 o'clock is the purely internal pile mass which has prolapsed, and 11 o'clock has got into what you call the internal external. And this one is prolapsed thrombosed pile mass in the E. Picture E is prolapsed thrombosed pile masses. So on inspection, you can make out whether it is external, it is internal, or whether it is internal or external. So now you remember these pictures because the treatment will also vary as per their presentation. So when it comes to Fissure-in-ano, okay, you can see there is the raw wound is there. The wound has happened at the anal verge, okay, which is given to the edema, perineal edema here. And at the same time, once you see this with the speculum, you can be able to make out, see here, a torn mucosa is there. In the middle picture, torn mucosa and the fissure, and here the same. Okay, so you are able to see the fissure, which is the 6 o'clock fissure is, and it has got a torn. And perineal abscess. Now, two conditions are the perineal abscess and Hysterectal abscesses. Always they come with an acute pain and the bulging at the anal region or perineal region, which will not allow the patient to sit comfortably. So even both prolapsed piles, prolapsed piles which has inflamed, as well as the perineal and Hysterectal abscesses, they won't allow the patient to sit on the chair. Even if you are asking them to sit on the chair, they try to avoid, and they say that no, sir, it pains. So that confirms that there is either collection or the prolapse of the mass. So the common areas, you can see here how the fistula tract also gives. Okay, so the common areas of the pus collection is here A, if you see on the left hand side, okay, that is the hysterectal area where the hysterectal abscess is occurring. And the same with the B is the deeper one, upper one, and this is the side of the hysterectal fossa again. This is a deeper fossa and superficial, and this is a D is a perianal, and this is again the perineum. Okay, perineal abscess C. Okay. So coming to the fistula always you can easily make out if you see any leaking opening, which may be leaking with the blood or a pus, that will confirm you the fistula. So Goodsall's rule you can apply here to understand what is the tract. So anal warts are there, multiple anal warts. This is more common, especially, and even you need to rule out any STDs also, because uh, many times with STD, these what you call the anal perineal warts, they come. And pruritus ani, okay. So pruritus ani secondary to hypertrophic papillae or decongested, what you call the congested internal piles can give pruritus ani. Carcinoma in anus, it presents in varied formation. Only thing what you should be aware of is if it is very hard. If the mass is very hard, that is also should be suspected as CA. If the mass is very fragile, bleeds on touch, that is also the CA. So you should think. So both the extremes, too hard, too soft, too fragile, both can be the CA. That you need to keep in mind. So don't attempt, don't promise the what you can handle by Ayurveda if you are suspecting any of this. So you need to rule out. See, we should know know our limitations. Once we know our limitations, we'll be safe. At the same time, we'll be doing quality work for the patients. Okay. So rectal prolapse, as I was telling, the circumferential, you can see here in the circumferential prolapse, which is maybe partial or maybe complete. Now, this if you see segmentation here, you are seeing a segmentation in the picture number B, you are seeing a segmentation here. This segmentation shows that they are the prolapsed pile masses. It is not a rectal prolapse. Rectal prolapse always comes in a circular fashion and it is circumferential. There is no segmentation in the rectal prolapse. In a prolapsed pile mass, there will be segments. And finger invasion test is negative in case of rectal prolapse. That is the differentiation how you should make out. Now, I was telling ulcer, at the end of that, if there is a skin tag is there, this is what a sentinel tag. And once it gets inflamed, that becomes more painful along with the fissure, acute fissure. If there's inflamed sentinel pile mass is there, that becomes more painful. And this is not a overnight it comes. It is multiple times patient has suffered with the fissure, but he has never noticed it. It must resolve by itself because that he had never visited a doctor. And whenever any ulcer heals, any fissure heals, it will leave behind some small amount of skin. And that small amount of skin over the period, as multiple the episodes of the fissure occurs and it heals, that skin goes on growing, and that makes a central pile. Okay. And then another common entity, what you should be differentiating it from fistula-in-ano is the pyloric sinus. Pyloric sinus, of course, by area you can make out. Pyloric sinus at the perineum area or nearby perineum are always at the natal cleft, in between the two buttocks. Okay, so pyloric sinus is more common there at the lower, at the pelvic area. Other than that, pyloric sinus can occur at the axilla, okay, and even at the web of the spaces where the barbers, if he is by the profession barber is there, means wherever the hair is going to penetrate into the skin, there the pyloric sinus can occur. I have operated a pyloric sinus at the anal regions and the postnatal areas as well as in the axilla. So ulcerative colitis. See, these things now, what I am going a little bit beyond the anal region and rectum region, because see, most of the OPD level, whatever the disease you will get, especially anal problems, don't only think of local pathology. As I told already, the Grahani Vikara, Atisara can lead to any anorectal conditions because Arsha cannot be only piles in Ayurveda. Arsha can be referred to any prolapsing masses, okay, at the anal region or any other region. All of them can be called as Arsha. So Arsha cannot be equal to only piles. Even C of anal region, C of rectum can be considered as Arsha. Okay, so because of that, so pathology when it is lying above, and if you give only treatment symptomatic, and if you do not understand the pathology properly, then you may fail in the medicinal management. And that is where the beauty lies. You need to always do the abdominal examination. Unfortunately, many of us, we miss the abdominal examination whenever the patient comes to us, especially in GP. We listen to only complaints and we prescribe, and a standard protocol is there for all the general practitioners. They'll prescribe one antibiotic, one analgesic, and one laxative, and one ointment for local application without examining the part. How many of you do that? If you are doing that, give me a smiley in the chat box. Okay. So most of us, we do it because of the one is It may be the load of the patients in the OPD. Many patients are sitting outside and you don't have time to that, or it may be because lack of examination also, lack of examination skills. So that you need to understand. Okay, you need to think about the higher pathologies or the higher problems. What can be this one? Okay, so these ulcerative colitis, Crohn's disease, okay, and the what you call the irritable bowel syndromes, these should also be considered for the anal rectal complaints, proctitis. Okay. So, because see, the IBS, Crohn's disease, and the ulcerative colitis, they coexist, and many times they lead to the problems related to the anal region. So, fissure I have found very much commonly associated with either ulcerative disease, ulcerative colitis, or the IBS. So, unless you treat ulcerative colitis, IBS, this fissure is going to recur. So, you need to focus your treatment at the root cause. Okay. So distal examination is for identifying any intra-rectal or intra-anal pathologies if they are not visible, because the ano-rectal examination comprises of the what you call the three. One is on inspection, second is the distal examination, third is the proctoscopic examination at the OPD level I am speaking about. So when you're doing a distal examination, you need to hold your finger parallel to, or it should be placed parallelly on the anal verge and pointing above, okay, at the median raphe, and palpating at the pulp should be palpating the anal verge. Then you gently slide your finger, okay, then allow it to slide itself in the anal verge from the anterior midline. So once it gets into, then you should advance into the what you call anus and the rectum, so that you can understand what is the sphincter tone, whether it is hypertonic, lax, or the normal, whether you have got any intraluminal palpable masses, intramural or extramural. Okay, and prostate in case of male should also be examined, and in case of female, cervix and uterus should be, and even bladder can be palpated, and based on that you can coexisting conditions can also be identified. Now, once you come out of the distal examination, of course, so you can make out the palpable masses, but uncomplicated, okay, uncomplicated first degree, second degree piles are non-palpable. So your distal examination cannot rule out there no existence of the piles when they are in the initial stage. So you need to make the proctoscopic examination. Okay. So if any bleeding is there at the tip of your this one, and if you are feeling a mass high above or in the anal region, and it is very soft, very hard, but at the same time when you come out, if it bleeds on touch, then CA should be ruled out. And especially when you are suspecting ischiorectal abscess, patient is complaining of fever or the chills. Even if he doesn't remember the fever, he may be feeling that chills was there. He experienced chills before few days or maximum 1 week. And he comes now with a severe pain in the pelvic region or the anal region, and he is not able to sit. He's a discomfort. He is uncomfortable. And then when you do the distal examination, if you need to look at the pelvic cavity, you should palpate. That is what I was speaking about, the extraluminal masses for the palpation. So if you are able to palpate any lump, either of the lateral side of the rectum, it can be ischiorectal abscess. So if the history of the fever or chills is there, acute sudden onset of the pain is there, and there is a lump palpable, okay, that is always ischiorectal abscess, which is many times it is missed because it doesn't cause any discoloration on the skin because it is deeper side. And it will take a lot of time to come to the skin surface because the deep space is there. And because the patient may not be having that brown discoloration, induration, and because of that you may miss it. And that may lead to fistula if it is missed in the earlier stage. So distal examination becomes very much important in that aspect, especially when it is considered, when it is with relation to any pelvirectal growths, lumps, abscesses. That you need to keep. That's why never ever quit distal examination in the what you call the ano-rectal complaints. So abdominal examination is compulsory. Do abdominal examination. see the any abdominal tenderness is there for ruling out the any ulcerative colitis or the Crohn's disease or the colitis for that matter. Rule out any hepatomegaly because it may be a secondary piles may be there, hemorrhoids may be there, secondary to portal, what you call the hypertension or the liver, what you call the hepatomegaly or the what you call the portal stenosis. So abdominal exertion mandatory. Okay, and even Cox abdomen is going to cause the fissure, fistula. So if the abdomen is tender, okay, you need to, and it is associated with the evening rise of temperature, and it is associated with what you call the loss of appetite, loss of weight. You should always think of Cox abdomen. So this abdominal examination is mandatory. Don't skip the abdominal examination. Okay, so that you can rule out the basic pathologies, whether it is gut related and is a major problem or it can be manageable or it is only because of the leaky gut. Second is dental examination. And third one is, as I told, the proctoscopic examination. Now, proctoscopic examination, of course, whenever you see a bleeding PR, you should advance for the proctoscopic examination to rule out any other conditions like other than piles, hemorrhoids, especially CANS, CA rectum. Okay, ulcerative colitis, ulcers, proctitis, Crohn's disease. Okay, hypertrophic anal papillae. All of these can be visualized on the proctoscopy. Contraindications are toxic megacolon, of course, doesn't come into your OPD. Pseudomembranous colitis, okay, rare. Suspected perforations, abdominal examination will help you to understand it. Okay, by that you can avoid the proctoscopic examination. And rectal biopsy, if already patient underwent rectal biopsy, don't be curious to see what has happened there, especially a week before or after. Okay, possibility of CA in ulcerative colitis and pregnancy, don't do proctoscopic examination. Because many times what happens, pregnant ladies, they come in the first trimester or this third trimester with the complaint related to anal region, especially fissure and the constipation and pain at the anal region. So don't do any proctoscopic examination in that, especially first trimester and the third trimester. Okay. So proctoscopic examination, I believe that all of you know what is proctoscopy and how it is done. So I will not be going into only one thing you remember. Don't ever introduce proctoscope in the 90-degree. Always slide it, as I told, as a finger you are sliding from the anterior midline, from the median raphe, in the same fashion. When you hold the proctoscope like this, you point it towards the anal region, you point it towards the midpoint, 12 o'clock. Okay, and then press gently on the external, what you call the external anal sphincter, so that the sphincter will relax. And then you can slide it down and then go parallel to the sacrum. That should be the precaution you should take. And the only contraindication as per me now, especially on the OPD, because what you'll be commonly getting is the acute fissure-in-ano. In case of acute fissure-in-ano, when the hypertonic spasm, so what sphincter is there, never attempt the proctoscopic examination because it may lead to vasovagal shock. Even distal examination is contraindicated in case of fissure-in-ano. Okay. Sigmoidoscopy, of course, you need to refer. If you are able to do in your OPD, I don't think so, because rigid sigmoidoscopy you may attempt, but it should be carried out in aseptic conditions. So don't do this, but you can refer it for ruling out. If you suspect on abdominal examination, any abdominal pathology, especially ulcerative colitis, based on the history, blood and mucus mixed stools, okay, and abdominal pain and tenderness, and if you are suspecting Crohn's disease or ulcerative colitis, or then you, and in a splash of blood is in the what you call the stools, okay, then you should research sigmoidoscopy and colonoscopy. Okay, so history taking I already have told you. So increased frequency with improperly formed stools, that will be IBS. Increased frequency with improperly formed stools, constipation, and tenesmus associated with abdominal pain can be Cox abdomen, you should rule out. Increased frequency with improperly formed stools, constipation, tenesmus associated with abdominal pain, and mixed with blood and pus, ulcerative colitis should be ruled out. And tenesmus with the left lower abdominal lump. Tenesmus means what? Tenesmus means unfruitful defecation. Means patient gets the urge for defecation, but once he goes and sits there for defecation, he feels the sensation. He feels that defecation sensation, but he doesn't pass anything. So it is a futile exercise. That's called tenesmus. Okay. So, so CA sigmoid and colon, CA, these are the probabilities. So what I want to highlight here is, whenever the patient comes with an ano-rectal complaint, don't only think that it is maybe simple piles. You need to think in a broader aspect. So you need to examine abdomen. You need to know the history, how and what will be presenting complaints may lead us to. Okay. So the good thing is that ulcerative colitis, Crohn's disease can be well managed with Picha-Basti by our Ayurveda. So there we can help the patients. Why I'm giving these list of the diseases, even though the ulcerative colitis and IBS and the Crohn's disease, they are not much having the good result with the allopathic medicine. Okay, you can help them with your Ayurvedic medicines and Picha-Basti. So, Mr. Fever history, already I told you how we can connect how we can understand fever with or without the swelling and the pain at the anal region, especially with perineal region and perineal abscess, historical abscesses, and the ruptured fistula, okay, and ruptured abscess secondary to Cox abdomen. Okay, pain. Now, this is very much important. If the cutting type of pain is there, it can be the simple piles, simple piles with the associated with constipation. And if the pricking type of pain is there, okay, that can be again the vata jarsha you can consider, or the dry constipation with what you call the uh, pain at the anal region, or the anal bulgings. Whereas if it is dull-aching pain, fullness at the anal region, that can be congested internal piles. If the burning is there, burning pain is there, then that is most often fissure or the proctitis or the what you call the congested or inflamed pile masses. Okay, that can be even colicky pain, abdominal pain associated with that. If the anal region pain is there, then you should go think about the Crohn's disease, other gut problems. Okay, so already I have told you in the what to call the anal examination, distal exam, how the distal examination procedure can help us. So I will be skipping this. Now the main question is, how can we help? How we can help the patients? Okay, so whether we can help or not. So as Sushita says, there is a Beshaja, Kshara, Agni, Shastra. These four modalities are there for the Arsha. Even though he says it's the Arsha, we can apply it to all the anatomical conditions of the anatomical conditions. So whenever they are not, so basically he makes two classifications, Drishya and Adrishya. So Drishya means once they are on inspection, if you can make out. Once they're either if their internal piles are there, if they're prolapsing outside, that is called Drishya. And even when you use proctoscopy, then also when they become visible, that also can be considered as Drishya now, because Arsho Yantra has been mentioned, and Arsho Yantra is for Vekshanartha, and he's told that when it becomes Drishya, that should be the Adrishya, means that can be treated by the medicine. Adrishya is which only mucosal sliding is there. There is no exactly what is the formation of the piles. That can be considered Adrishya, or even the congestions or the proctitis, okay, or even the Grahani Vikaras. The secondary to that, whatever the patient is feeling burning pain at the rectal region, anal region, that is what, especially proctitis, fugax, what I was telling, fugax, proctitis. All these things can be considered on the Adrishya. Okay, Adrishya. So in the Drishya, he has given again three. One is Achirakala Jatani, Alpadrishani, Alpalingopadravani, Beshaja Sadhyani. So if the complications, the presentation is very minimum, the complications are minimum, pain is minimum, the mass is minimal size, okay, congestion is there, very minimum, then you should go for patient. But when it is this very much prevalent and they are soft, spread, they don't have stalk where you can apply the Kshara Sutra or make an hemorrhoidectomy, then you go for Kshara Karma. And when it is, they're hard, they're rough to touch, okay, they're hard and they're non-bleeding and they're external, covered with the skin component, can be considered as Vata Jarsha, Kapha Jarsha, and you can go for Agni. Okay. And if the stalk is there, there is stalk, and the prolapse, what you call the pedunculated mass is there, we can go for Shastra. So this is what the main thing you need to understand to make a prescription. Whatever I have given, this is available everywhere, and we are always we must have come across all those things, which was very much repetitive for you. But this particular slide will help you to understand what medicines you should finalize, should take up into consideration when you're making a medical management. See, as I told you, Drushya, Adrushya, Arshas. Okay. So Adrushya, Arshas always in Anta Parimarjan Chikisa. That is always, I told you, the Agni Chikisa you do Vatan Lomana, you do Agni Deepan and Pachana. Your 99% of the complaints will subside. But when it become Drushya, Arsha, okay, again, there are both the things should be applied based on the stage. If there is Drushya only by proctoscopy, not prolapse outside, then again there is a chance of Bheshya Chikitsa. But once they are prolapsing outside, without proctoscopy you are able to make out, then the medicinal management has got limitation. You need to think about Anushastra Karma, parasurgical procedures or the surgical procedures. Okay. So Anta Parimarjana is Shodhana Shamana. By Parimarjana, in case of Drushya Arshas, only by proctoscopy I am speaking about. Okay. That is Dishna Lepa, so Karanjadi Lep, Taila Lepa has been mentioned, but I have not practiced. Swedana, Avgaha Sweda, Parisheka, Dhoma, these can definitely help the patient. Whereas Shushka, once they become either the Drushya or Adrushya, if they are Shushka, they are dry, non-bleeding piles, okay, non-bleeding entities, then if they are associated with Baddha Mala Pravurti, constipation, hard stools, then always do Udavartavata Chikitsa. Means Vatan Lomana should be the priority. Laxatives, bulk formation laxatives should be given. Samsana, Sukhavirechaka Dravya should be given. Vatan Lomana. Whereas Bhinnamala Pravurti is there should be Atisarava Chikitsa should be made. So Sangrahi Dravya should be given there. Now you can decide. So you have got a good number of what you call the prescriptions, the medicines for the anal or the piles. We are having a lot of medicines. Asavas are there, Arishtas are there, Gukulus are there, Churnas are there, Grithas are there. Okay. Then now you should identify if the Baddhamala Pravurti, with the Baddhamala Pravurti, okay, non-bleeding are there, Udavarta Chikitsa. If the Bhinnamala Pravurti is there, then non-bleeding are there, Atisarava Chikitsa Sangraha. Okay. Ardra Arsha, which are bleeding, okay, they are Raktati Pravurti. Then again, you should go there, Pittaja Atisarva Chikitsa, Rakta Pitta Chikitsa, because you need to do the Agni Deepana also, Amapachana, and Pitta Samshamana, at the same the Rakta Prasadana and the Rakta Stambhana. So for that, you need to go for Rakta Pitta Chikitsa or Pitta Jatisar. Now, I'll give it. I won't take you much into the classical one. Okay, I will summarize it one now. Now, if it is any of the left-hand side, list of the left-hand side, then it is your role. You have got the role to play here. Left-hand medicinal management. Okay, left-hand side of the slide. Fissure-in-ano, you can definitely do it as a general practitioner. First and initial stage of second-degree hemorrhoids, you can definitely help them with Ayurvedic medicine. External thrombose piles, you can definitely help. I'll give you how you can make it. Ulcerative colitis, you can help. Okay, only with Shamanaushadhi. Pruritus ani, you can help. Proctalgia fugax, you can help. Inflammatory bowel disease, you can help. Proctitis, you can help. Whereas right-hand side, they are purely surgical or parasurgical. Medicine will only give them temporary relief, not the permanent relief. So, sentinel tag, rectal polyp, Fistula-in-ano, perianal abscesses, second and third degree hemorrhoids, spinal sinus, anal warts, rectal prolapse, and CNS always should be referred to an Ayurvedic surgeon and general surgeon or the proctologist. Don't try to attempt with these people, these particular conditions. You send them directly, so that will be doing justice with the patient as well as you will be regarded for that. Okay. Whereas medicinal management, the left-hand side is always you have got to pay. Now, the best prescription, what I have used all these days, and I am using now also. Okay. So, as I told you, Fissure-in-ano with loose stools and bleeding if the patient comes to you. Because as I told, Baddha Malava Pravurti and Bhinna Varchas Pravurti. These two conditions patient will come. Because fissure, many of the times it is seen secondary to diarrhea. Many times. The patient reported to me with a Fissure-in-ano, and they give history that they had diarrhea a week before, or 5 days before, or 3 days before. And they, especially when the Pitta Jatisara is there, they'll definitely come with the Fissure-in-ano. Okay. So that's what I'm telling you. Loose tools, along with the bleeding and the Fissure-in-ano is there, where the Saraguna Vruddhi is there, Pitta Vruddhi is there. Pitta Vruddhi is Dravata Vruddhi of the Pitta is there, and Saraguna Vruddhi is there. So you need to stop that. You need to do Pitta Shamana. You need to do Dravata reduction of the Pitta. Okay. And you need to do the Sangrahi. You need to do Sangrahi. For that, you can use Arshognavati. Okay. Drakshadi Kashaya and Mustakuttajarishta. Mustakuttajarishta is best preferred over the Drakshadi Kashaya. Okay. Mustakuttajarishta gives a very good result. But only thing you should remember is that, okay, usually Asa Varishta, if they do not have Amapachaka Aushadhi, don't use them when the patient is in Amavastha. Patient, if he is having Amavastha, don't use Asa Varishta because it will be Abhishandi and the Ama will be Amla Pitta, Amlata, Vidagdata, Amla Vidagdata will increase. Patient will have the burning epigastrium and all the what you call the Abhishandi Lakshanas will be there. Amla Pitta Lakshanas will be occurring as a complication. But in the Musta, especially it has got Amapachaka. So you can use it by diluting Musta Kuttajarishta with double time of the water or the equal of the water. So patent drugs, capsule mebarate, especially SC phytopharma. Okay, I always use it, especially when the patient comes with Fissure-in-ano with the loose tools. Capsule mebarate is better preferred over capsule, what to call the other any what the drugs what are in the market. And again, here is a disclaimer. I am not promoting SC phytopharma, but the combination of that mebarate is good to give the result. So if you find it's the same composition, okay, in other available market products or classical products, you can go with that. Okay, because I was practicing in a rural area where Ayurveda was not much used, and I was supposed to look for the available medicines. And in the available medicines, as SC phytopharma was available even with the allopathic medical shops, I started using them. So because of that, I found it is easy for me and I could find the result. And that's why capsule mebarate, okay, and even capsule sunarin can be used for the bleeding piles or the loose stools with Fissure-in-ano. Raktastambakoti of Dut Papeshwar is very good. Nimbadi Ugudu of SDM pharmacy, Udupi is very good. Okay. Ointment Kusmolin is actually of Kumar Pharmacy, Bangalore. Okay. That is very good, especially for local application. Even Sukuda ointment of IU Labs is very good. Arsheta ointment of the Dut Papeshwar can also be used. Tablet Meftal Spaz you can use from the allopathic side because but you need to integrate things because pain when it comes to pain management, whatever the Ayurveda medicines we can use, but they cannot give immediate result. So for that reason, to have the confidence of the patient in you, you should always integrate your prescription with the allopathic analgesia. You need to. So that patient will develop confidence in you, and afterwards they will stay with you, and then you can manage you can shift totally towards the what Ayurvedic medicine. What I do is first 3 days I give allopathic analgesia along with my prescription of the Ayurveda, and definitely the patient will reduce the pain within 2 days, and the patient will stay with us. Okay, you can use Meftal Spaz, which is antispasmodic mefenamic acid is there. Okay, antispasmodic you can use, or you can use NSAIDs, especially paracetamol and diclofenac combination. I found very good result with that. Hot seeds bath we can prescribe. So you see that whether these things can be made easy, you mean they are available in and around you, that is better. You can pick up from these things and you can prescribe and you can see the result. Okay. Fissure and first degree hemorrhoids with loose stools and bleeding, again, the same. As I told, capsule sunarin is there from the ST phytopharma. Ovarian syrup, ban. Even the ovarian syrup indication is for what to call the menorrhagia, metrorrhagia, PCOS, okay, especially scleroga. But I have been using ovarian for especially these bleeding piles, where because it has got Sangrahi Dravyas also, it has got Vatanoloma Dravyas also, it has got Shotahara Dravyas, it has got Balya Dravyas, and it has got what you call the Raktastambhaka Dravyas. So ovarian syrup, ovarian capsule tablet, can be used. Capsule mebarite again the Ashwagandha, Mustakotajase, Bilwadi Leha, Gangadhar Churna can be taken out. And I was telling the another same. Fissure with constipation and bleeding. Constipation and bleeding now. See, this is another combination. Fissure is there, constipation is there, and the bleeding is not from the internal piles. Bleeding is from the fissure, that fissure. Okay, there you can use again Drakshadi Kasha is the best preferred because it does Vatana Lomana and at the same time it does the Pitta Shamana and Balya. Okay, and that can be, and it is laxative. Drakshadi is laxative. Vatana it does the Sukha Virechana. Amruta the Uguru can be used. Okay, because the Pitta Shamana, Tikta Rasa is there, Pitta Shamana is there, Agni Dipana is there, and it will help the wound healing faster. Therefore, Gugulu you can use. Okay, it's so universal. Pancharita Grita Gugulu, especially Pitta Prakriti person is there. Okay, and he is having what you call the especially diabetes, associated with diabetes, and Pancharita Grita Gugulu can be best. And Amla Pitta Mishrana is a wonderful suspension, what you can get of the Dudh Papeshwar, and usually I prescribe it 20 ml QID directly without any dilution on empty stomach. One thing I would like to tell you, all of you, okay, you need to prescribe all the Ayurvedic medicines, especially when you are using for ano-rectal conditions or the pelvic pathologies or the below umbilical pathologies. Always give all the Ayurvedic medicines before food because it's Apanavata Vikriti. So for Apanavata Vikriti, Pragbhukta medicine management should be there. Many of my students, they copy my prescription, but they fail to advise this before food. They give after food and they don't get the result. And they call me, sir, we give the same medicine, but we didn't get the result what you are getting. So they make that mistake that before food, all the medicines of the Ayurveda, especially I'm speaking about the Ayurveda medicines, which you are using for the ano-rectal conditions or any of the below umbilical region, any pathologies, always use before food. All the allopathic medicines, especially analgesias, except antacid, use always after the food. If you are giving antibiotic also, you can use after the food. Okay. Then fissure and first degree hemorrhoids with constipation and bleeding. Okay. So here again, constipation and hemorrhoids with first degree hemorrhoids means bleeding is now from the hemorrhoids, not from the only fissure. It's from the hemorrhoids. Okay. Then you should again, the same prescription can go, but the dosage you need to increase. And Herbolax from the Himalaya can be used as a laxative. Okay. And Amruta Guru from our classical side, you can use them. Okay. And thrombosed external piles. Thrombosed external piles, classically what it says, allopathy paper means modern science, what they say, if thrombal pile mass is there, you give a nick, evacuate the thrombus and you need to clean the wound and you keep it weak. But most of the thrombosis pile masses, when they report to you initially, you can manage them only with medicine and of course integrating because I always use antibiotic with especially O2, ofloxacin, 1 BD for 3 to 5 days. And diclofenac with ceratopeptidase, diclofenac, paracetamol, ceratopeptidase. Because ceratopeptidase will help the declotting. The thrombus will be, what you call, thrombolysis will take place by ceratopeptidase. And diclofenac and paracetamol, if this mega combination is there, definitely the patient will get result immediately because it is so much painful that patient want pain relief immediately. So you need to look into that and use these two drugs. And along with that, Amla Pitta Mishrana, Himbadi Guru, hot seeds bath. Okay, hot seeds bath is necessary because it will help the thrombus to reduce. So Rakta Skandana takes place. Rakta Skandana can be avoided by hot seeds bath. Don't give cold seeds bath. Don't give cold seeds bath even in Fissure-in-ano. Even though burning is there, always preferred is hot seeds bath. And prolapsed thromboid pile mass. Okay. Prolapsed thrombosed pile mass. The internal pile masses, they have prolapsed outside and they are stuck there. A strangulation has taken place and they have become into thrombosis. They have developed thrombosis. We can apply Panchitha Grita over it. Try to push it inside. Okay. And because see, reduction of the prolapsed strangulated pile masses, inflamed prolapsed pile masses is very much mandated to avoid the thrombosis. Okay, avoid thrombosis or strangulation. So always try to put them inside, okay, with gentle pressure. Okay, cold, if they are not going, give cold application of the ice cube should be taken into the your gauze pieces. Try ask the patient to apply it there. So that and even magnesium glycerin can also be applied. Magnesium glycerin can also be applied. Okay. So fistula-in-ano, as I told initially, of course, it requires a surgical intervention. But as a clinical practitioner, you need to give the first prescription. So always, when the Vataja Kafaja Bagandhara is there, try to give your first prescription as Bagaja Uguru, Trifla Uguru, Yogaraja Uguru, Mahayogara Uguru, and Amruta Uguru as a laxative, and Pittaja Bagandhara, Panchatrita Uguru, Chilo, Chiru, Vilvadi Kashaya, and refer the patient towards the what we call surgical management. Now, parasurgical surgical procedures that can be summarized are now hemorrhoids can be managed with, especially the hemorrhoids of second degree onwards. Okay, later stage of the second degree, third degree, fourth degree. Okay, they can be managed with Kshara Karma, Agni Karma. Agni Karma not for the internal pile masses. Agni Karma for external pile masses, which are only covered with skin, not covered with mucosa. Kshara Karma for covered with mucosa. Okay, ligation excision for both internal, external, international. Cryotherapy, I have tried, but not a good result. Barron's rubber band ligation, it's OPD basis. You can try it, you can learn it. It is easy procedure without bleeding, no anesthesia required. You can easily do it, so you can learn it. Okay, injection of sclerotherapy, the same as a Kshara Karma. It is can be done. Infrared coagulation, you can keep infrared coagulation first degree. Initial first stage of second degree hemorrhoids can be best treated with infrared coagulation without any invasive procedure. And you can, in your OPD, you can do it. So think about having an infrared coagulation for the initial conditions so that you can make a good money as well as you can give good result for the patient. Circumferential stapling is again specialized one. Doppler guided hemorrhoid artery ligation technique, you need not to think about that. Fissure-in-ano, anal dilatation is the surgical, parasurgical one, which when the very hypertonic sphincter is there, and because of the defecation, during defecation, patient gets a syncope. He falls down because of the pain. Vasovagal syncope he is getting because of severe pain. That requires under spinal anesthesia, anal dilatation. Never attempt anal dilatation under local anesthesia in the OPDs. One finger dilatation, two finger dilatation. Whenever you see any hypertonic sphincter, don't do that. Okay. Plain thread ligation is usually done in the Fissure-in-ano, or Kshara Sutra ligation is done. I am not much of that because it doesn't make any sense, or rather, I didn't find it makes any help. But Matra Basti and Matra Basti can help for the Fissure-in-ano, acute Fissure-in-ano. Okay, in a more better way, need not to go for thread ligation. Okay, you ask the patient to come for your OPD 7 days. You yourself give the Matra Basti and ask the patient come after food or take the food and come to you. Give 60 to 70 ml of any Ksheerabala Taila or any Madhura Gana Siddha Tailas. Ksheerabala Taila, Dashmula Taila, Bala Taila, Balashwanda Taila. Gratas also you can use. Estimadu Grata you can give. Estimadu Taila you can use for Matra Basti. And patient will have very wonderful result and you can charge for that. And Fistula-in-ano, the surgical and parasurgical procedures which you need to refer for them is the Kshara Sutra ligation, fistulectomy, fistulotomy, Taila Daha, that is even the burning, means a hot oil can be poured into the track, okay, and even Agni Karma can be done, and Kshara Jala infiltration can be done, plastic surgery by various techniques. So these are what you need to know because you need to refer the patient and you should educate the patient. These are the procedures available. And for that, you can go to the other thing if you are not able to do this. Okay. So for that guiding, it will be there. So Kshara Karma procedure is what if you want to know because it is not much practice. That's why I want to show you some pictures. Usually with the protoscopic, we expose the pile masses. We scrap over the mucosal part. Then we apply the Pathology Kshara, that is a paste of the Kshara, not Kshara, so the Kshara, and we'll leave it for 120 seconds to 150 seconds, 130 seconds, and then it turns to, once you wipe it out with the swab, okay, you'll find a blue discoloration, purple discoloration of like a jamun fruit, and that indicates that there is a chemical coagulation happened. Okay, then the sclerotherapy means the what we call the the chemical cauterization, the way the blue congestion, the venous burning has taken place, sclerotherapy has occurred, and by that, if it is not occurred, you can repeat the procedure, and this is the procedure, and keep it with wash it with Nimbu Surasa to nullify its further action. If you do not wash with Nimbu Surasa, patient will complain of burning, and the kshara will penetrate into the beyond the anal wall and even into the pelvic cavity, and the patient will have severe burning pain. So immediately after, once you achieve this blue discoloration, purple discoloration, jamun foot-like color, you should wipe it with this normal saline and then wipe it with Nimbu Surasa or any sore juices. Maybe orange juice, maybe you can use kanji, you can use takra, you can use glycerin also. Glycerin also you can use. But better is Nimbu Surasa, it is easy to use. Immediately you can wash it. Wash it two to three times with Nimbu Surasa so that further cauterization can be stopped. Further cauterization of the healthy tissue I am speaking about. So when you are applying this kshara, surrounding healthy tissue other than pile mass should be covered with swabs so that the healthy tissue should not be burnt. So after 5 days of the kshara karma, you can see there is no pile mass. Pile mass has shut off. Okay. So Agni Karma, by cautery, you can cut these external pile masses. Okay. By not this is classical cautery, but I used to do thermo cautery. I used to do thermo cautery. Even what dithermic cautery also you can use to cut this one. But thermo cautery is better, not the dithermic cautery which we use in the OT. Once you use the dithermic cautery in the what we use in the OT, it will cause more burning pain post-operatively. But when you use red hot cautery, okay, red hot cautery, that is thermal cautery, post-operative burning pain is not seen much. Okay. Even Jaloka can be used in the OPD basis, especially when thrombosed rectal pile massage, but I didn't get much result, so I don't recommend it. Okay. Rubber band ligation, the picture you can see here, the black color rubber band is there. So it is again the same Kshara Sutra application like that only. Here you will be using the what you call the Baron's and a gun, this one. Okay, Baron's gun, rubber band ligator, which you need to catch hold this one through the protoscope. Will be entering with the Baron's gun, and you'll be catch holding the pile mass. And once you push the trigger, the rubber band automatically goes and tucks around the what you call neck of the pile mass. So it will set off after the necrosis after 7 to 10 days. Okay, this is Baron's technique for pile masses. Okay, so this is higher radio frequency coagulation for piles, which again should be done under the expert over this one. And Doppler guided hemorrhoidal the artery ligation. This is again a specialty, so let us skip all these things. Okay, ligation treatment. This is Kshara Sutra ligation. If you have done any certification course for 6 months or 3 months, if you have got hands-on training, you can do the Kshara Sutra ligation. Okay, and leave it. Don't cut the distal part of the mass. In hemorrhoidectomy, what we do? In hemorrhoidectomy, we do the transfixion of the mass, and the distal part we excise. In Kshara Sutra ligation, we'll be only tying the Kshara Sutra and leaving it to fall off on its own after the necrosis after 7 to 10 days. Okay. For Fissure-in-ano, as I was telling, Matra Vasti you can do in your OPD basis. Okay. You need to lukewarm. You need to make the oil lukewarm. Don't give cold oil. Lukewarm. Make it lukewarm. And with 50 ml syringe or 600 ml syringe, you can push it with the red rubber catheter. Red rubber catheter of 6 number or 7 number. 5 to 7 number red rubber catheter you can use. You can use, apply it on the nozzle of your this one, what you call the what you call this syringe, and take the taila or the krita, whatever the Madhura Siddhagana, and push it for 60 to 70 ml once in a day after the food. And patient within 2-3 days, patient will be free from the fissure. Okay. Perineal abscess management, IND. So if it is very small boil is there, you can try with modern antibiotics. Okay, very small boil, I am speaking, very small boil. But if the big, huge induration is there, don't give antibiotic and don't make the patient to suffer with the either antibioma or leading to fistula-in-ano. Refer it to either surgeon, or if you are efficient enough to do incision drain under local anesthesia, you can carry out. Okay, fistula again, refer it for Shastra application. That is the best one. So method of probing for the fistula, just for your information, I'm putting it. If you already seen, that's well and good. If you are not seen, just have a look how they do it. Okay. So this is how they tie. From the external opening, they enter. They make another internal opening. If it's not existing there, then they come out. They put the they tie the thread across, and they allow they change the thread once in a week. So the thread will be cutting from both the side, 1 centimeter per week, and fistula track can be burnt and cut off. Okay. So rectal prolapse, partial prolapse I have operated, but in OPD, you can try partial prolapse under local anesthesia with what you call Thier's procedure, but any medicinal management is not effective in the rectal prolapse. You can do Vatanulomana. Okay, you can give some muscle strengthening like proteins or the mouse, what you call the prasadaka dravyas, so that if the partial prolapse is there, especially young children, you can avoid the surgery, and by grow as per the once the muscle tonicity improves, it will subside by itself by after the 5 years of age. Okay, so pulmonary sinus, as I already told you, the modern people, the contemporary people, they say there should be Jed-plasty or the excision of that and followed by the plasty. But usually we can do Kshara Sutra application in the pulmonary sinus or excision followed by Kshara Karma or Agni Karma and lay it open to heal secondarily. So that has got better non-recurrence. It has got better result. Recurrence rate is very less. But when it go to the excision and suturing, recurrence rate is more. Okay. So these are some of pictures of the pulmonary sinus. So this is what perineal abscess, once neglected, can lead to necrotizing fasciitis. That's why you should be very much sure to examine before sending patient out of your OPD only with the precision only on history, listening the history. Don't consider any anal pain as only piles. It can be perineal abscess also, which may turn out to be a life and threatening. Necrotizing fasciitis may take place, which may lead to septicemic shock, death. So always be careful. Okay. Last summary is there. Okay. Parikartika, classic say, modern names are the fissure, complaint burning PR. Management is conservative, that is, do the Pitta Shamaka Dravyas, Vatanulomana, Matra Basti. Okay. If it is burning with a streak of blood on stool, again conservative. Guda Vidrati abscess, severe pain with perineal swelling and incident drainage. Arsha, hemorrhoids, okay, painless bleeding, drop or streamwise. You can go for Kshara Karma, infrared coagulation, sclerotherapy, transanal hemorrhoidal dearterization or conservative management. Raktaja Arsha, Raktaja Arbudha, CA rectum, consider as CA rectum, painless bleeding. Painless bleeding, always you should be careful. In surgery, always painless is very dangerous. In surgical, what you call the OPD, painless is always dangerous. Painful is very good for us. Painless is always dangerous. So always you should become more vigilant when the patient comes with the painless bleedings. Okay, painless bleeding. Or the acute pain was the severe pain was there, sudden stoppage of the pain, especially abdominal. Always you should be vigilant. Okay, so painless bleeding, splash of blood, refer it for oncosurgeon. Kaphaja Arsha. Kaphaja Arsha is hypertrophic anal papilla, can be considered under Kaphaja Arsha, or third degree internal pile masses which are covered with the fibrous white sheath can be considered Kaphaja Arsha. So severe itching at an anal region can be Agni Karma can be done. Arsha internal piles, rectal prolapse can be the internal piles. Arsha can be internal piles, rectal prolapse also. So prolapse of the mass is there, surgery. Arsha can be external piles and internal piles, external chronic canal bulgings, painless, conservative management. Arsha can be external thrombosed pile mass, inflamed internal pile mass. So external chronic anal bulging will be the presentation with pain. So analgesia and evacuation of the clot. Bhagandhara and Nadi Vruna Vidradi, which can be compared to fistula, Bhagandhara, Nadi Vruna, pyloric sinus or the sinus, Vidradi is abscess. Okay, soiling of the undergarments may be there once they are leaking. So Kshara Sutra, Kshara Karma, Agni Karma after excision can be preferred. Okay, so you need to refer if you are not able to sentinel tag, rectal polyp, fistula-in-ano, perineal abscess, second, third degree hemorrhoids, sinus warts, rectal prolapse, and CA. Okay. So where to refer now? Okay, for conservative management, first degree hemorrhoids. Okay. Sorry, let me come. First degree hemorrhoids for conservative management, Fissure-in-ano, you can manage it. No need to refer them. For surgical, parasurgical management, second, third, fourth degree hemorrhoids, external piles, fistula, perineal abscess, ischial abscess, anal warts, sentinel piles, you can refer it for Ayurvedic surgeons. Okay, CA-ANS only for allopathy medicine surgeons. You can refer CA-ANS and complete rectal prolapse because it requires major surgery. So refer better for the allopathic surgeon. Of course, if our Ayurvedic surgeon is competent enough to do that, we can refer to them also if you are nearby in your vicinity if they are there. But the middle section, always refer them for Ayurveda Shalya Tantrajna. Okay, these conditions. The first condition, first category, first column is for you. You can manage it. Second column is for Ayurvedic Shalya Tantrajna. Third column is for allopathic surgeons. Okay. So conclusion is that abdominal and local examination, abdominal and renal local examination, already I have emphasized why it is necessary in the anal conditions. Okay. So acute fissure-in-ano, piles of first degree can be effectively managed with basic chikitsa without complication and reoccurrence. Acute on chronic fissure with hypertonic sphincter, subcutaneous small fistulae, ano-rectal abscess, thrombose external and prolapse of internal piles, and other malignant ano-rectal conditions require purely surgical intervention. Second and third degree hemorrhoids can be better treated with either Kshara Karma or Kshara Sutra as per the need. Okay, so that is what you need to think about. So now, if you have got any questions, okay, so let me stop my screen sharing so that if you are already the member of Ayurpreneur Academy, or if you are having the or access to the what you call the, if you have downloaded the Ayurpreneur Lifestyle Hub mobile app, if you are not able to see the feed section, that is because you have not bought any paid membership there. So if you are interested to take the journey of Ayurpreneurship, you have got options to go there to purchase the what you call the courses at the storefront of the mobile app. In the storefront, there is a silver membership is there, Ayurpreneur silver membership at 4,999. There is Ayurpreneur Success Blueprint course is there for 999. And for device, Ayurpreneur device goal setting formula is there. If you are very much confused what to do with your career, and if you want to set the goal for yourself, I made a small what you call the course on how to decide our goal and set the goal. For that, you can go for Ayurpreneur device goal setting formula, which is for 499. And if you are thinking about starting an entrepreneurship, so basics element of the entrepreneurship, what you need to, how you need to prepare yourself. There is Ayurpreneur Success Blueprint, and there you can go and take four. That is also for 499. By that, you'll have feeds, access to the feed section where I'll be putting the feed of the in relation to learning of the Ayurveda and the entrepreneurship and clinical practice and other things as and when possible. And at the same time, you'll be getting the notifications of all the future webinars, weekly calls, even though you may not be registered, but you'll be included in that and you can directly access from the mobile app. Okay, so if you have got mobile app, kindly keep on watch or make the notification on in your mobile for this app, so that whenever I schedule any video call or what call the webinars or the any video calls, you will get a notification popped up in your what you call the notification bar in your mobile, so that they can come to know that I have set up a video call. Otherwise, emails will be coming from my side. Okay, so I'll be inviting a lot of other people. So every week Friday, I'm committed to show up myself in front of you and share my knowledge, whatever I'm having. Okay, I'm also learner, and whatever I have learned, I want to pass it to you people. And if you have got anything to add on, that is welcome. So with that, I think as there are no questions. Okay, there is a question from Dr. Chaitra. Sir, how to manage pediatric case of Fissure-in-ano? Very good question. So, Dr. Chaitra, usually the conditions they occur, the the different stages. As in my clinical practice, I have seen the infants because of the constipation and the diaper rashes. Okay, they use when you use diapers, and if you have the child is coming from the hot climate, and the hygiene is not properly maintained. Because of that, also there will be uh, very minute, invisible scars will be there by the itching. Okay, or when the mother is wiping, if she is washing with her hands, okay, many times there may be a injury by the mothers also. So because of that, that can be the one reason where the fissure occurs in the infants. Second is when the fissure the infant suffers with dysentery or the loose motions, especially when it is foul smelling or sore smelling, yellowish, watery stools if it comes, that can also cause the fissure-in-ano. So there, the best remedies and the good thing in the infants is the fissure heals very fast. So what you can do is home remedies already the ghee can be applied. Ask the parents to apply the ghee. Otherwise, if you have got Shatadauta Grita with you, you can prescribe Shatadauta Grita for local application. Because the internal medicine is not much required in the what you call the infants. Internal medicine not much required in the infants, because as I've seen in my career, only with local application. Because already if they're on the breastfeeding, that is the best medicine, best food what they're having. So there is apathy is not much. Only this has occurred because of the either constipation when the child has been given along with the breastfeeding, the oral up the what you call the external feedings are started. Okay, external feedings are started. Then there may be certain hard stools may be occurring. So in that condition, you need to ask the mother to add the ghee, much of the ghee in the material food what she prepares, and most of the time fiber and crushed and liquid food should be given, and the hydration should be maintained properly. And third is the medicine. In the medicine aspect, you can give what you call the crushed, okay, crushed draksha, or drakshadi kashaya can be with a very minimal quantity, less around 1 to 2 ml, or even 5 ml, up to 5 ml drakshadi kashaya you can use, and with dilution with the water. Okay, it can be over the day, whole the day, you can once in a day, I'm telling once in a day, 5 ml of drakshadi kashaya with the dilution around 4 to 5 times can be given to the child in the infant. When it comes to the children, toddlers as well as children up to the age of 10. Okay, there you can use Amla Pitta Mishra, you can give. One BD, Nimbadi Guru or Tripura Guru can give. Okay, and of course for application, the either Shatatagrita or Shatatagrita even available now in the market with in the tube form, tubular form, in the ointment form, in the tubular, in the tube it is available. So that you can advise, or you can advise any patent what you call the ointments, especially I told you, Sukkada ointment is best. What you call the Kusmulin ointment is best. Arshayat ointment is best. So these can be given for the local application, and ask the patient to keep the child, ask the parents to keep the child away from the junk foods, okay, vapors, all the what you call the ruksha, what we say, and especially these what you call the parsana or the besan. Okay, the besan used medicine food should be avoided, and the proper food should be maintained. And internal medicine is also not much. The Amla Pitta medicine does the wonder. Can give Amla Pitta medicine at the 10 ml TID or QID you can give, doesn't make any harm. Along with that, you can give seeds bath is recommended for both this especially the children, and application of the local ointments. Okay, and when it comes to the teenagers, especially 15 plus, they remain same. You can increase the dose, either Tifra Guru Q, Nimbadi Guru Q, one Guguru with the laxate, with the Vata Lomana Dravyas. Okay, and one what you call the Pitta Shamana Dravya, especially as I told, Amla Pitta mission is best acceptable because it is sweet also, and local application and says bath and food, the Patya Patya. One thing I would like to suggest here for all of you, many times even patient does the same mistake and even our practitioner do the same mistake. That is, they go for excessive intake of the curd whenever they find the burning burning in these two, burning in the anal region or the piles or the any complaint related to anal region, especially burning and bleeding, the people are advised to take a lot of dahi or the curds, thinking that it becomes cold and it gives the relief. But unfortunately, that dahi being abhishandi, it will aggravate the condition and patient will have severe burning sensation will be aggravated and bleeding will be increased. So this thing you need to take care. Don't ask the patient to ask the patient to avoid curds, ask the patient to avoid daytime sleep, ask the patient to avoid night sleep awakening, ask the patient not to indulge in sexual activity, okay, ask the patient quit the tea, tobacco ingestion, or the smoking, and any alcoholic this one, and the spicy foods as well as the non-vegetarian. Okay, ask the food patient to not to take the what to call the other than green gram. All the other grams should be avoided. Okay, green gram or the moong dal is best. Tuvar dal should be avoided. Chana should be avoided. Okay, and this will help the patients. Okay, by that they will get the relief. And most of the time, patya will help to cure 80% of the disease without medicine also. So that's why the alteration in the diet can help a lot. That's why, as being an Ayurveda doctors, you have better knowledge about the patya, and you adjust their food, adjust their daily routines, and give our Ayurvedic medicines. Definitely, 90% of the inner conditions which are not entered into the surgical stage as per the classical advice, we can manage in your OPD. Okay. So thank you, Chaitra, for asking that question. So that I believe that I have elaborated and you are clear about your doubt. Okay. So if any other people are having any, yes, thank you for the confirmation. If you have got any other questions, any of you can, you are welcome. Okay. I am ready to give my time, another 10 minutes or 5 minutes, whatever, depending upon the interest of the participants to ask the questions. Because unless the students are ready, teacher cannot arrive, isn't it? So at the same time, I request all of you to give your feedback, especially on the app. You can go app and the Google Store, Google Play Store, and give the feedback rating on the App Store. Or you can, if you take the screenshot of this screen, okay, and if you can post on your social media handles, that will be a favor for me. If you are really benefited by this session, and if you would like to recommend to join this weekly master classes for your classmates, and if you want to help them, and if you really find this is what is my mission is there, it is worth to be shared, I request you to take a screenshot of this screen and post with your what you call the on your social media handles. That will be a great favor you'll be doing for the uh, mission what I am carrying out. Okay. So thank you one and all. So there are no further questions. I hope if you have got any questions, you can chat with me. My WhatsApp number is 99450 79276. 99450. Let me put it in the chat box. 99450 79276 is my WhatsApp number. So if you get any questions, if you have got any questions, you can post here. If you are a paid member of the Ayurpreneur Lifestyle Hub, you can post your questions in the feed section of the Ayurpreneur Lifestyle Hub platform, or even in the message also section, you can put your message. Okay. With that, I thank you, all of you, for being here till the end of the session. And I love you all. And I wish all the best for your this one learning of the Ayurveda. And hope we'll be building a universe of the Ayurveda, and we'll be living a true life of an Ayurveda Vaidya that I told, by achieving social significance, professional significance, time freedom, and financial abundance. Okay. So see you next week on with either me or some other expert. So be in touch with this academy, Ayurveda Academy, Ayurveda Lifestyle Hub. And also I request you to subscribe for my YouTube channel, Ayurpreneur Academy, if you are still not subscribed for that. And also I request you to promote that YouTube channel. And this, what you call my mobile, the Ayurpreneur Lifestyle app to your friends so that they can join for the weekly webinars. See you in the next week. See you.